So good afternoon, everybody. My name is Jamie Underberg. I am a clinical assistant professor of medicine at NYU School of Medicine and also work at the NYU Center for Cardiovascular Disease Prevention. However, full disclosure, I am not a cardiologist. I'm a lipidologist, and I also direct the lipid clinic at Bellevue Hospital in New York, which is a large city hospital. It's actually one of 12 city hospitals, and then about 15 other ambulatory care settings that all refer to our lipid clinic. And for the next couple of months, I'm actually the president of the National Lipid Association. And I'm going to be talking to you today about PCSK9 inhibitors and lipid management in patients with increased risk for cardiovascular disease. Hopefully try to pique your interest in this particular area, in this field. I think it's a growing and exciting area in clinical medicine. I will tell you that the National Lipid Association is a great organization for anyone interested in the management or care of patients with lipid disorders. We're a non-denominational organization, meaning you can join as a physician or as a nurse or a dietitian or a pharmacist. Anyone who's involved in the team-based care of patients with lipid disorders is welcome in our organization, and every one of those subspecialties has actually risen to be president of the organization, and I think that's unique amongst medical organizations, which is probably why ours continues to grow. I will also tell you that we have a key interest in young members and trainee members in our organization, to the point that we have 3 meetings a year. And prior to every one of those meetings, we run a 2-day course called Lipid Academy, which is actually changing to Foundations in Lipidology. That course is free for fellows and anyone in training. And if you are interested in coming, in addition to the course, one can receive a stipend for travel of $500. So it's kind of nice. We don't have an unlimited number of these, but usually they're available if you want to go. Our next meeting is in San Antonio in February, and our annual meeting is in Las Vegas in May. So just some information about this program. It's sponsored by the North American Center for Continuing Medical Education, and its development was sponsored by educational grants from both Amgen and Sanofi, and myself and several of the faculty members were involved in putting it together. For some reason this is gone back. These are the learning objectives. We're going to review clinical evidence that supports a treat-to-goal approach to hypercholesterolemia management, discuss the latest clinical trial data for PCSK9 inhibitors, identify appropriate patient candidates for PCSK9 inhibitors, and talk a little bit about the clinical trial data and how we might consider that, applying that to patients who might benefit from these medications. So I always start with this slide when I talk to any group about lipids and lipoproteins. Lipidologists don't use the term LDL hypothesis because it's not a hypothesis. LDL is causal in ASCVD, or atherosclerotic cardiovascular disease, and there are several very strong lines of evidence that support this. I'm not going to spend a ton of time going through this. Suffice it to say that both epidemiologic data, observational cohorts, support this association of LDL cholesterol and risk for ASCVD. Experimental, mostly animal data, supports, again, the causality of LDL in ASCVD and the ability to lower LDL and actually reverse anatomical representation of ASCVD. There's therapeutic data with interventional trials, both with medications and even non-medication studies. Among the classic was something called the POSH trial, where part of the intestine was removed in patients who had inherited lipid disorders, and they had a reduction in ASCVD events. And then most compelling, I think, is some of our newer data, both genomic and genetic data, suggesting that in patients who have mutations that raise or lower cholesterol and often mimic the interventions that we utilize to lower cholesterol, they also seem to show a similar correspondence with atherosclerotic cardiovascular disease risk. So this is one of the data sets I was telling you about, secondary and primary prevention trials, most of these with statins, some of them with statins and ezetimibe, and the POSH trial up here, done as a surgical intervention, all showing a log linear relationship between LDL cholesterol and ASCVD event rates. The secondary curve is always a steeper curve than the primary curve, right? And the reason for that is that the risk is higher in these patients. When we think about the reduction of risk in lipid lowering, absolute risk reduction is based on 3 key factors, and it's important to remember that. The inherent absolute risk of the patient. The higher the risk of the patient, the greater the benefit is for any degree of LDL lowering. The second is the absolute change in LDL, meaning milligrams per deciliter, not percent reduction. So if you have a 50% reduction in LDL and go from 200 to 100, that's a greater absolute change than going from 100 to 50. And that's important to remember. And then the third key determinant of absolute risk reduction is how elevated the LDL cholesterol is, which is why patients with severe elevations in LDL cholesterol benefit to a greater extent when it comes to lipid-lowering interventions. So this is just one example of the impact of LDL lowering across the spectrum of inherent risk of patients, meaning the greater the risk of the patient, the more likely you're going to see a greater reduction in cardiovascular events. When we talk about genetic data, it informs us both with regards to LDL and then some of the confusing data about our attempts over and over again to modify HDL cholesterol. So here what you see on the left is the odds ratio for changes in LDL cholesterol and observational or epidemiologic evidence of ASCVD event rates. And no surprise, LDL cholesterol is a nice predictor of events. And as we've always known, at least from observational data, HDL seems to have an inverse relationship, right? As HDL goes up, risk goes down. As HDL goes down, risk goes up. But when you look at genetic data, people who were born with mutations that either raise or lower LDL from birth, no surprise, the odds ratio has actually increased. Why? Because of the temporal relationship of the risk factor. The longer you are exposed to high LDL cholesterol, the greater your risk of having a cardiovascular event. That's why patients with familial hypercholesterolemia are at such significantly increased risk of cardiovascular disease, because they have elevated cholesterol from birth. Similarly, if your LDL cholesterol is low from birth, you seem to have a protective effect that is multiplicative as compared to interventional trials later in life. But when you do the same genetic analyses for HDL cholesterol, the odds ratio is essentially 1. It doesn't seem to make a difference, which again tells us that attempts to raise or lower HDL cholesterol probably are fraught with confusion and disappointment, which is where we are right now. We know that when you get to very low levels of atherogenic lipoproteins, LDL cholesterol or ApoB containing lipoproteins, there seems to be a continued progression of reduction in risk. Now, this is a series of lipid-lowering trials, mostly with statins, showing that as you move further down the LDL cholesterol curve, the adjusted hazard ratio for ASCVD events continues to go down. What you should not take away from this slide is that taking someone from an LDL of 75 to 56 is something that we should be doing. What you should take away from this is that the trend to lower LDL seems to be a beneficial trend. We'll get into whether or not intervention at low levels of LDL cholesterol actually makes sense. Despite what we know about LDL cholesterol lowering and all of the safe and I think relatively reasonably priced interventions that we have to do so, we still are not doing a great job at getting patients to their desired LDL cholesterol levels. Whether you believe that it's simply a 50% reduction in LDL cholesterol, as stated in the 2013 guidelines, or whether you believe it's a numeric goal of less than 100 or less than 70, based on the endocrine guidelines or the National Lipid Association guidelines. What you see here is that when you look at patients with CHD, the ability of get these patients to LDL cholesterol goals of less than 100 or less than 70 is still not where we want it to be. In addition, a disease that I spend a lot of my time treating, familial hypercholesterolemia, these are patients who have LDL cholesterol levels often greater than 200 when we first meet them off medication. You can see that when we compare our attempts here in the US in red, this is our own US called Cascade FH Registry, versus registries in the United Kingdom or the Netherlands, the abilities to get patients to their LDL goal of less than 100, which is one of the two accepted goals for FH, or a reduction in LDL cholesterol of greater than 50%, are again not where we would want them to be. So despite the fact that we know that these patients are at high risk and they benefit from aggressive lowering, our ability to achieve the desired goals that we target is not what we would like. It's interesting that when we look at the percent reduction in LDL cholesterol, one of the things that we've learned is that despite everyone's misinterpretation of the guidelines, it's not just about the prescription or actually getting a patient to take a medication. It's about documenting that they're actually adherent to the medication and they get the expected response to the medication, right? How many people thought when the guidelines were first published in 2013 that if someone was high risk, all you have to do is put them on the drug? That's not enough. You actually have to put them on the drug and actually make sure they responded the way you would expect them to. So this is one of my favorite studies. It's a post hoc analysis of the Jupiter trial, which was a study looking at patients at moderate risk for ASCVD who were treated with rosuvastatin versus placebo. And the trial was stopped early because the patients given rosuvastatin had a dramatic benefit in protecting against cardiovascular events. So they went back and they looked at the actively treated group, the patients who all got statin. They all got the same dose of the same statin, 20 milligrams of rosuvastatin. And what they discovered was that there was a dramatic heterogeneity in response. Some people got up to an 80% reduction in LDL cholesterol, and others had actually no change at all in their LDL cholesterol. This is a group of patients who all got the same dose of the same statin. So the bottom line is you have no idea of how someone is going to respond to a medication unless you actually measure and test and see. But what was most fascinating about this trial is that the risk reduction correlated exactly with the change in LDL. So not only is it important to measure LDL to determine response, but that response actually predicts outcomes, which is why checking and following up is so important, which is why removal of this as a metric of a key indicator was one of the craziest things that I've ever seen in my life, and hopefully we can reverse this process. So the authors of this study actually said that when you're thinking about going beyond statins, the group that might have the greatest benefit of adding additional or non-statin therapies is the group over here that had the minimal response, right? Because the groups over here, they already got down to relatively low LDL cholesterol levels. But the groups with minimal response may be the ones who most likely would benefit from adding another agent. So we have a lot of recommendations and guidelines to manage lipids. I would tell you, more than I think anyone reasonably would desire. We have a new set of guidelines that's currently now being produced, and I think hopefully will supersede all of these and we can get rid of them. We published this article a couple of years ago. One of our fellows was the primary author. We started out thinking we're going to look at all of the guidelines and dissect them and come up with all the differences between them. When we finished writing the paper and we were writing our summary and conclusions, we realized that the guidelines have far more in common than they actually are different. And that's what I want you to remember. What do they have in common? The first is that they're all risk-based, right? You have to evaluate the risk of the patient. There may be different ways to evaluate risk. Use a calculator or add up risk factors. But the higher the risk, the more intensive the therapy. That's number one. Number two, they all include lifestyle modification as the first step. Number three, statins are the cornerstone of pharmacologic therapy. Why? Because they're cheap, they're safe, and they work. And finally, they all also recommend non-statin therapy, despite what many people might disagree with. Even the ACC-AHA guidelines in 2013 said in high-risk patients who do not achieve the expected response to statins, consider using non-statin agents that have been shown to be efficacious and safe. At the time, there were no studies showing that adding a non-statin to a statin gave you further cardiovascular risk reduction. But since then, we actually do have data that supports that. So they were fairly prescient in the way they thought of this. The National Lipid Association in 2014 published recommendations. Instead of looking at percent reduction of LDL cholesterol, which is what we saw in the ACC guideline, suggested goals of LDL targets or non-HDL targets, very similar to what we had seen in the ATP recommendations a couple of years ago. But what I want you to take away from this is, again, the risk evaluation. Evaluate the risk of the patient first, and then initiate drug therapy based on the LDL cholesterol level. The Europeans in 2016, very similar way of approaching patients. Prescribe a statin to the highest recommended dose in high-risk patients. In cases of statin intolerance, you can use non-statin agents. In patients at very high risk, despite persistent high LDL cholesterol levels, or if they have statin intolerance, you can consider using PCSK9 inhibitors, and we'll talk about that. In 2017, the American Association of Clinical Endocrinologists published an update to their lipid guidelines. They actually created a new category. It was called extreme risk, which I'm still trying to understand. I was talking with a colleague of mine the other day. I decided extreme risk was someone with very high cholesterol who drives really fast. But the bottom line is extreme risk are patients, obviously, with ASCVD and multiple risk factors. And they came up with a new goal of an LDL cholesterol less than 55. Now, this is based primarily on the results of the IMPROVE-IT trial, which I'll show you in a second, showed that when you added ezetimibe on top of a statin, you took people from an LDL of 69 to about 55 and further reduced their risk of ASCVD events. I'm not sure that this cycle of lower and lower goals of LDL as a target is something that is going to be productive going forward. I will tell you that I'm going to show you the data from the FOURIER trial showing that patients given a PCSK9 inhibitor went from 90 to 30 with their LDL. Does that mean that 30 should now be the new goal and this should be revised? I would tell you probably not, because again, getting someone to an LDL goal of 55 if they're at 56 probably doesn't do anything, right? Because I already told you, it's about the absolute change in LDL, and it's about how high an LDL level you start with. So if you start with an extremely low LDL, you either have to have extraordinarily high risk or have to move the bar a lot to actually make a difference when it comes to further reducing the risk of ASCVD events. So we've talked a bit about some of the genetic data sets, but I want to show you a little more and how this informs us not only about LDL as causal in ASCVD, but also how we think about interventions and how they might further assist us in lowering the risk of cardiovascular events. So this is some data that actually started the whole story about PCSK9 inhibitors. Now I'll tell you PCSK9 stands for proprotein convertase subtilexin kexin type 9. You have to say that 3 times fast to be a lipidologist. But the bottom line is that early in the last decade, Helen Hobbs and Jonathan Cohn at UT Southwestern, they said, you know, we're really interested not in the mean, but what's going on in the patients who have the very low levels of LDL cholesterol. And they identified mutations, 2 different ones, in PCSK9, one in African Americans and one in Caucasian patients, that were associated with reductions in LDL cholesterol. On average, somewhere around a 28% reduction over the course of the lifetime in LDL cholesterol. And this translated to almost a 90% reduction in ASCVD events. Now, the best statin trials only lower risk about 35–40%. This is double that. But remember, these are patients who have a mutation from birth. So the temporal relationship of the risk factor over the course of the lifetime is what drives this reduction in events. And at about the same time, a little later, right before we actually had data from the IMPROVE-IT trial, we had some fascinating data looking at another protein, Niemann-Pick-C1-like 1, which is the transport protein in the gut that ezetimibe inhibits, and it's how it lowers LDL cholesterol. These patients have a loss of function of NPC1L1 and have on average a lifetime lower LDL cholesterol of only 12 milligrams per deciliter. Yet a 12 milligram per deciliter reduction over the course of the lifetime translates to almost a 50% reduction in ASCVD events. So both PCSK9 and NPC1L1 mimic, at least mechanically or mechanistically, the effects of PCSK9 inhibitors and ezetimibe. And interestingly enough, both of those agents have now been shown on top of statins to reduce the risk of atherosclerotic cardiovascular events. And so interestingly enough, I showed you in the beginning that slide of secondary and primary prevention. Now I'm showing you a similar slide, but what you're looking at here now are pharmacologic interventions on the bottom, later in life, right? And these are genetic mutations in patients that mimic pharmacologic interventions, yet people have them from birth. So the curve is much steeper when you have the problem or the benefit from the time you're born, as opposed to down here when we decide to intervene later in life, and probably less effectively. So again, this informs us not only about risk and causality, but about potential therapeutic interventions. Now, I've talked a bit about the IMPROVE-IT trial. These were patients post-acute coronary syndrome who were on simvastatin at a moderate dose, and then given ezetimibe in the actively treated group. And you can see here there was a mean reduction of LDL cholesterol over 7 years from about 69 to 53. And that correlated to a statistically significant but small reduction in ASCVD events. The number needed to treat was 50, but this was over 7 years. Typically, statin trials have similar NNTs, but that's over about 4 to 5 years. Again, these patients were at very high risk, but they had a small change in LDL, and they started with low LDLs. So you would expect small changes in ASCVD event rates, and that's indeed what was seen. Interestingly enough, though, if you plot the results of this study on the cholesterol treatment trialist curve, which is primarily a collection of statin trials, the results of IMPROVE-IT fall exactly on the line. So people often talk about the pleiotropic effects of statins, the non-LDL lowering effect of statins. And I would tell you that indeed statins do have non-LDL effects. They have anti-inflammatory effects. They have effects on nitric oxide and vascular reactivity. They have effects on oxidation. But the bottom line is that when you use other medications that have similar LDL effects, but none of those pleiotropic effects seems to fall exactly on the same risk reduction curve. So when people ask me, is the ASCVD event rate effect of statins based on LDL lowering or something else, I would tell you I believe it's LDL lowering. And there may be other effects, but the LDL lowering seems to be where all the benefit is accrued. So I want to talk to you about one other statin trial, which was the HOPE-3 trial. This was a trial done in Canada about a year ago now. It was an attempt to actually assess the benefit of a polypill in moderate risk patients who were given blood pressure lowering medications and cholesterol lowering medications when neither was indicated by current guidelines. The blood pressure lowering arm showed no benefit, but the lipid lowering arm, in patients who were actually at higher risk than they were initially assessed by their practitioners, which is another interesting rule of thumb. We all tend to underestimate risk when we guess it, showed a significant reduction in ASCVD events. Now, when this trial was first published, the authors said, aha, it has nothing to do with the LDL, because we treated people independent of their LDL. And look at this, they got a similar benefit all the way along the LDL curve. But when you plot the results of HOPE-3, it falls right on the cholesterol treatment trialist curve, again suggesting that it is LDL related. It's all about the cholesterol. So now I'm going to segue to PCSK9, and I already told you a bit about the early discovery phase of PCSK9 from the Dallas Heart Study Mutations. At about the same time that people were looking at low LDL, there was a group of investigators looking at patients with familial hypercholesterolemia, typically caused by mutations in the LDL receptor or the ApoB gene. And what they discovered was a group of families who had classic clinical FH, but no identifiable mutations. And they were actually able to isolate gain-of-function mutations in PCSK9 for these patients, associated with high LDL cholesterol levels and increased risk of ASCVD. So low LDL, low PCSK9, low risk, high LDL, high PCSK9, high risk. You can see how attractive this was as a new target for LDL lowering in those interested in this space. So how does PCSK9 work? PCSK9 is involved in controlling the catabolism of the LDL receptor. I would tell you that every drug we have that modulates the LDL receptor and does it safely has been shown to reduce the risk of ASCVD events. Bile acid sequestrants as monotherapy in the Lipid Clinic research trial a long time ago. Ezetimibe in combination with statins, and now PCSK9 inhibitors. How do PCSK9 inhibitors work? Well, here's the LDL receptor. The LDL receptor is made in the liver and secreted to the surface of the hepatocyte, where it binds LDL particles and it clears them back into the hepatocyte. When LDL receptor complexes are internalized, they are endocytosed and form an endosome, which actually fuses with the lysosome. The contents of the lysosome then break down the contents of the endosome, which are essentially lipids, cholesterol and triglycerides. And before we knew about PCSK9, our assumption was that the LDL receptor was left untouched and simply recirculated back to the surface of the liver to live another day. But it turns out that this PCSK9 protein that you see here that looks like a little kidney bean-like structure is also made in the liver, and at the same time that the receptor is secreted to the surface, PCSK9 is secreted into the extracellular space. PCSK9 then actually binds to the LDL receptor complex and is internalized. And when PCSK9 is present, it does two things to the LDL receptor. The first is it actually acts as a tether. It increases its residence time in the endosome. Hence, it is exposed to lysosomal enzymes for a longer period of time. The second is it changes the conformation of the receptor, exposing a catalytic site that allows proteases in the lysosome to break down and destroy the receptor. So when PCSK9 is present, the receptor is destroyed, and it can't recirculate to the surface of the liver to clear more cholesterol. So people often call PCSK9 a chaperone protein. But I would tell you it's not the kind of protein I would want taking my daughter out to dinner. Because if PCSK9 takes you out, you don't come home. It's not a good thing, right? So now you remember how PCSK9 works. So you can imagine, how do PCSK9 inhibitors work? Well, PCSK9 inhibitors that are clinically available now are monoclonal antibodies. And they're actually injected, and they find their way into the extracellular space, and they bind PCSK9, stopping PCSK9 from binding to the receptor LDL complex. Hence, when it's internalized, the receptor is left untouched, and it recirculates back to the liver to clear more cholesterol. So giving a PCSK9 inhibitor seems to enhance expression of the LDL receptor. What it's really doing is delaying degradation. And so it allows the receptor to clear more LDL cholesterol. And you can see we have two clinically available PCSK9 inhibitors, Evolocumab and Alirocumab. They're very similar agents. In fact, one was suing the other over patent problems, so you can see they're really pretty similar. They achieve a steady state after about 12 weeks. Their maximum effect is in 4 hours. In 4 hours, you give these drugs, PCSK9 levels go to 0. LDL cholesterol takes about 10 days to 2 weeks to get to its lowest level, but it never goes to 0. So why is that? Why can't you make cholesterol levels go to 0 if you can make PCSK9 go to 0? Well, there are several reasons. The first is we're constantly consuming cholesterol. The second is the liver is always making cholesterol. But the third and most interesting is that PCSK9 is not the only way we break down the LDL receptor. Like everything else in the body, just like the angiotensin converting system, there's always another backup mechanism. And when it comes to degrading the LDL receptor, there's something called IDOL, I-D-O-L, that stands for intracellular degrader of the LDL receptor. It's a non-PCSK9 ubiquinone-mediated system that actually is involved in degrading the receptor. So I mentioned a little bit about the drugs. They're both indicated for patients with ASCVD or familial hypercholesterolemia. Evolocumab is indicated in additional for homozygous FH, whereas Alirocumab is only indicated for heterozygous FH, the less severe form of the two conditions. They can both now be given subcutaneous every 2 or every 4 weeks. The every 4-week dose of Evolocumab is indicated for homozygous FH. And their side effects are similar. They're very well tolerated: nasopharyngitis, injection site reactions, and hypersensitivity reactions. I have some cases, but they take some time, and I'd rather actually get through the data, so I'll go back to the cases if there's time at the end. But I want to show you the clinical data with Evolocumab. It lowers LDL cholesterol about 60%. This is monotherapy. 60%. That's greater than any statins used at their higher doses for monotherapy. What's interesting is that once you get to the maximum reduction in LDL cholesterol, increasing the dose further does not further lower LDL cholesterol. What it does is it increases the duration of the effect. So the 4-week doses, as opposed to the 2-week doses, are simply higher doses. And what you see here is that on average, whether you give it every 2 or 4 weeks, you get the same mean LDL reduction. In patients with familial hypercholesterolemia, who actually have defects in the LDL receptor, you see similar reductions in LDL cholesterol. Why? Because at least in those with heterozygous FH, half of their receptors work normally. And that's plenty for a PCSK9 inhibitor to actually upregulate. I told you about the safety of these drugs. It's interesting, they slightly increase liver function tests. I, for the life of me, can't tell you why. It's not an indication to measure LFTs, and there's no risk of liver problems in the patients who take these drugs. But it's still something that I puzzle about. I mentioned the injection site reactions and the stuffy nose. Stuffy nose is something interesting in New York. If a patient of mine had stuffy nose and I didn't tell them about it, they would probably end up the next time they came to see me having seen an allergist, an ENT, and having sinus surgery. So I always tell them they're going to get a stuffy nose when they take the medication. Headache, influenza, they usually last for about a day, these types of symptoms. And in almost all cases, patients are able to continue the medications. PCSK9 inhibitors also lower something called lipoprotein A. Lipoprotein A is the combination of LDL cholesterol with a protein called ApoA attached to it. ApoA elevations are associated with increased risk of not only ASCVD, but aortic stenosis and thromboembolic events, including probably one of the most common causes of stroke in younger patients. Whether or not this LP lowering A effect is beneficial or not, I have absolutely no idea, and we still don't completely understand the mechanism. But both Alirocumab and Evolocumab lower Lp(a) about 25 to 30%. We think one of the reasons may be, it's interesting, it turns out that PCSK9, once it gets into the extracellular space, exists not only as free PCSK9, but also bound to LDL, and then its greatest affinity is actually for LPA. And we know that the way PCSK9 is cleared is through the reticuloendothelial system. So it's possible that when you give someone a PCSK9 inhibitor, it actually targets Lp(a) for clearance through an alternative pathway other than the LDL receptor. So we're just going to have to wait and see whether or not this is a beneficial effect. The drug works very well in patients who are statin intolerant. It's interesting, PCSK9 inhibitors have been studied in patients who are statin intolerant. It's taught us two things. First is that it's better tolerated than statins in patients who are statin intolerant. But the second is that when you give drugs to patients who are statin intolerant and you don't tell them what they're getting, a significant number of them are fine with statins. And so statin intolerance is real, but at least part of it is perceived. Whether or not that's something that alters how you manage these patients or not is something to think about. Now, what about outcome data with PCSK9 inhibitors? Well, before we had the prospective randomized trials, we had some fascinating safety studies. The FDA now says that if you're going to develop a drug that lowers LDL cholesterol, not only do you have to show that it lowers LDL, but you have to show that it doesn't harm people. Well, why is that? Well, it's because there actually have been some trials with other classes of agents that lowered LDL and actually did bad things to people. So in two studies, one with Alirocumab and one with Evolocumab, these were evaluated over about an 18-month to 2-year period of time, showing not only significant reductions in LDL cholesterol, but when you actually go back and post hoc look at the cardiovascular events, the concern was whether or not you would see an increase in cardiovascular events. The expectation was that you would see no difference. These early studies, small number of events, showed actually a reduction here in about 50% of ASCVD events. And people got very excited about this. Oh my goodness, we're going to see a 50% reduction when we do the prospective randomized trials. And in fact, with the alternative agent, Evolocumab, similar reductions in LDL cholesterol, and believe it or not, similar reductions of about 50% in ASCVD events. Now again, this was not a trial powered to look at outcomes. It was a trial to look at safety. So there were a small number of events. But the trend was certainly in a positive direction. And for those involved in developing these drugs, it was very exciting. So that leaves us to the PCSK9 outcome trials. And kind of where are we right now? So originally, there were 3 of these drugs in development. The third, called Bocozizumab, actually ended its development program. Unlike Evolocumab and Alirocumab, which were fully human monoclonals, Bocozizumab was humanized, meaning it had some mouse in it. And it turned out that over the course of the trial, patients developed anti-drug and anti-neutralizing antibodies that limited the clinical efficacy of the drug, and they stopped the development program. There were no safety issues. The patients just lost the benefit of LDL lowering over time. So of these 2 trials, the Evolocumab trial, FOURIER, has been completed, and I'll talk to you about it. The Alirocumab trial, ODYSSEY Outcomes, is just finishing up right now, and we should hopefully hear these results presented at the ACC meetings in March of this coming year. So FOURIER looked at patients with stable ASCVD as opposed to ODYSSEY Outcomes, patients post-ACS. Stable ASCVD on high-dose statins in most cases, or at least maximally tolerated statin therapy, and in some cases other lipid-lowering agents. And then they were randomized to Evolocumab versus placebo. So what happened? Well, the first thing is that their LDL went down almost 60%, which is exactly what you would expect. Here it was 59, actually. And it actually took their LDL down 56 milligrams, from 90 to about 30. All right? So you went from a relatively low LDL to begin with, 90, to an extremely low LDL cholesterol level of 30 milligrams per deciliter. And this is the primary endpoint. It was a typical MACE, or major adverse cardiovascular event, CV death, MI stroke, unstable angina, or revascularization, showing a relative risk reduction of 15%. But interestingly enough, the absolute risk reduction was only 2%. Why was it low? 2% is what I showed you for improvement. It was low because the patients were at the low end of the LDL scale. The relative risk reduction was greater. Why? Because you changed LDL more than you did in the Improve It study. But absolute risk was still not particularly great. But one other thing that you have to look at here, when we compare absolute risk reduction, we often think of statin trials, which were given over 3 or 4 years. This was only over about 2.5 to 3 years. So it was a very short trial because it was event-driven, and there were a lot of patients in the trial. The secondary clinical endpoint, which was CV death, MI, and stroke, the one most of us are interested in, actually showed a relative risk reduction of about 20%. But again, the same absolute risk reduction of 2%. There was no benefit on mortality. That's one of the major criticisms of this trial. The drug didn't prevent death. Well, I would remind you that neither did any of these other statin trials prevent death over the last several years. Why? Because when you get people relatively well treated over a relatively short period of time, the only way you're going to reduce death is make sure they wear a seatbelt on the way to the clinical trial visit that day. Right? You really can't change total mortality anymore unless you treat people over longer periods of time. If you look at subgroups, no matter what the LDL cholesterol was, these patients benefited. And going all the way down to LDL cholesterol levels of around 20, the benefit seems to be a continuous one. And finally, when you compare the results of this trial and you adjust it for the duration of time and you match it up with the cholesterol treatment trialist curve of all of the other statin trials and the ezetimibe trial, it falls exactly on the same line. So again, it's about LDL lowering because PCSK9 does not change C-reactive protein. It's not an anti-inflammatory agent. Now, I told you about the bocazizumab trial. Interestingly enough, this was a trial done in high-risk primary prevention patients, people without ASCVD. The study was terminated, as I told you, after about a year. But interestingly enough, if you looked at the patients in the secondary group of those with an LDL greater than 100, you can see here the curves were already separating after 1 year. So higher LDLs, even in primary prevention, seem to suggest benefit. People often ask me, do I believe that PCSK9 inhibitors are a class effect? I will tell you absolutely. Do I believe that they are useful across a spectrum of risk? I would tell you absolutely. The indication right now is specifically for FH and ASCVD. So you cannot use these drugs in high-risk primary prevention patients unless they have FH. We do have a proposed treatment protocol for patients with FH. This was from a wonderful paper in Circulation published a year or two ago now. And it says that as patients move down this curve, and you've tried statins and or non-statin agents that are cheaper, it's reasonable to consider PCSK9 inhibitors. The National Lipid Association just published guidance on using PCSK9 inhibitors. We reiterated the indications of the drug, which are FH and ASCVD, but we also called out the group of those with statin intolerance. Why is that? Well, there have been some fascinating studies published recently showing us that in patients with ASCVD and statin intolerance, their risk of having an event is significantly greater than those who are not statin intolerant. That kind of makes sense because they're not taking their statins, right? But it calls out a group of patients at higher risk, like that group I showed you in the Jupiter trial who didn't respond to their statins and maybe would be the best candidates for adding on a new drug. Even the Europeans mentioned statin intolerance as a group of patients who might benefit from PCSK9 inhibitors. So where are we now? The American College of Cardiology has published a wonderful document. It's a focused update of their 2016 guidance on the use of non-statins in patients at high risk. It was endorsed by only one group, the National Lipid Association, I'm proud to say. And they looked at the 4 statin benefit groups: primary prevention, ASCVD, FH, and diabetes. And they went through all of the possible things to consider after statin therapy. Once you're done with that, they do mention that in patients with ASCVD, PCSK9 inhibitors can be used. And in addition, patients with ASCVD and comorbidities. This is if you've optimized your statin therapy and your LDL is still above your target goal. So in conclusion, LDL remains a central risk factor for ASCVD. Patients with low lifetime low LDL are at a low risk for ASCVD. And low LDL, though, can be associated with risk, right? Metabolic syndrome is the classic one. Low HDL, high triglycerides. So don't disregard low LDL. Just make sure you understand why it's low. Additional markers of LDL-related risk, such as non-HDL and ApoB, may better represent risk in these populations. And high-risk patients remain untreated. So the use of PCSK9 inhibitors offers us another tool in the management of these patients. And I will tell you what's fascinating. Recently at the American Heart Association meetings, we actually had a whole group of sub-studies now published from the FOURIER trial, looking at different populations within the overall study group. And they actually called out 2 interesting groups. The first were the patients with peripheral vascular disease. And I found this fascinating because in my institution, I often don't see these patients. They get referred from a primary care doctor right to the vascular surgeons, and then they end up back in the hands of the primary care practitioner. Well, it turns out that the patients in FOURIER who had peripheral vascular disease but did not have heart attacks or strokes, their absolute risk reduction, instead of being 2%, was 6%. It was 3-fold greater. So the peripheral vascular disease patient population in that study represents an extremely high-risk group that have significant benefit. Why that is? Well, maybe vascular disease represents disease in multiple beds, but I suspect that many of those patients don't get treated as aggressively as maybe someone who's had a heart attack or a stroke. And so there was greater benefit that could be accrued when they got a PCSK9 inhibitor. The other group of patients were when you risk stratified the patients in FOURIER based on MI, myocardial infarction. Patients who had one MI or their MI had been more than 2 years prior really didn't seem to benefit much at all. But patients who had an MI within 2 years or multiple MIs seemed to accrue the majority of the benefit with absolute risk reductions approaching 5% as opposed to 2%. So when we look at sub-studies of these large clinical trials, IMPROVE-IT as another example, and IMPROVE-IT, the only patients who really benefited in IMPROVE-IT from ezetimibe, does anyone remember who it was? The diabetics. If you took the diabetics out of the IMPROVE-IT trial, everyone else had no benefit. So the question that comes up when you've got an expensive drug like a PCSK9 inhibitor, which is $14,000 a year if you're paying cash, which hopefully no one ever has to, is should we actually tease out who are the subgroups in these patients and actually apply the therapeutic intervention to the patients at the higher risk? And is that an appropriate way to actually utilize some of these medications? I have absolutely no idea on whether that's reasonable or not. Again, when you look at a study, you have to look at the overall cohort. You can look at these smaller groups, and it gives you kind of a hypothesis for how you might go about looking at them in additional investigations. But this is where we might be going, and it's kind of fascinating, kind of a topic for conversation. So I will end with that. I've got about 8 minutes left. I'm happy to hang out here and answer questions, and I appreciate your time and attention. Thank you all very much. Does anyone have a question about this or anything else? I'm really happy to answer it. Anyone want to become a lipidologist?
What's been your experience in getting the PCSK9s approved by insurance who are obviously somewhat resistant?
We found that using the drug in the patients for whom it's indicated in, ultimately we've got close to 100% of our patients approved. But that doesn't mean that it requires a lot of time and effort to get there. Despite the perfect patient and the perfect submission, oftentimes there are initial denials that require resubmission. We put together some standard letters that we use now. We always submit a cover letter. Once you use the drug a lot, I often find the payers kind of know who's submitting it, and they're more likely to actually approve it. And there may be, this is one of the areas where potentially centers of excellence or referral centers may be the places to do this, because it's probably more time efficient for them to be doing it all the time than people to be doing it one-off and wasting a lot of their time trying to get it approved. But the few issues we've had are when we run into patients who just have plan exclusions. And then it doesn't matter how much we complain, the drug just isn't available to them. The other group that we've had problems with in our neck of the woods are our Medicare patients, where it's a perfect example of when coverage is not coverage. You can get the drug approved, but the copays are so high. It was actually a wonderful study just published in JAMA Cardiology showing that often for Medicare patients, the total out-of-pocket cost by the time the end of the year comes could be several $1,000s. And that's often more than anyone can reasonably afford. And so despite the drug being approved, they just can't take it. I had a patient like this the other day who called me up and he said, I'm not going to take it. I just can't afford the copay. It was $400 and something a month.
As a follow-up, after the publication of FOURIER, with the absolute reduction of only 2%, did it become harder or easier, or no change in getting coverage?
I don't think it changes that much. Again, it kind of is where you expected it to be. In retrospect, anything different would have been crazy. But realistically, it's not the LDL lowering, it's the cost. And so most people have said that a reasonable cost for these drugs would probably be around $3,000 a year, $4,000 a year. So at some point, they'll figure that out, and it'll get there. And until then, unfortunately, access will be less than desirable. But interestingly enough, if you remove cause from the picture, the drugs are very clean. They work well. I think they have a potential to be used in a lot of other situations, such as transplant patients, HIV populations, patients where there are a lot of other drug-drug interaction issues that often preclude the use of other medications. So it'll be interesting. They haven't been studied in kids yet, but potentially these could be a wonderful drug to use in children because of the tolerability. Obviously, they're injectable agents. That's not your first choice in treating a child, but we obviously use them in diabetic children without an issue. Any other questions? All right. Well, thank you all very much. Have a great day.